Hello. Thank you so much, sir. Uh, so, on behalf of AIOS, I would like to thank for providing me this opportunity, and Dr. Kamaljeet Singh and Professor Shrikant sir also. So, we'll be talking about BRVO studies and protocols. Mainly, the prevalence of BRVO is around 4.42 per thousand, and BRVO can be further classified as a major BRVO, which is an occlusion of a retinal vein that drains directly to one of the quadrants, or a macular BRVO, which is an occlusion of a venule within the macula. So, in BRVO, usually the obstruction occurs at the AV crossing, and this is a typical site for branch retinal vein occlusion. The main causes of vision loss in BRVO is macular edema, and as we can see in this OCT, there are multiple cystic spaces and inferior, and we can also know according to the OCT also that what type of retinal vein occlusion is present. And the other causes of vision loss is usually intraretinal hemorrhages. This is a fundus fluorescein angiography which shows masking due to the intraretinal hemorrhages. Then there is ischemia and neovascularization which can occur, and this is what we usually treat with the help of lasers. And if there is superior ischemia, then usually a sectoral laser is done. And if there is neovascularization, especially in this case, like there is neovascularization of the disc and multiple capillary non-perfusion areas can be seen in the superior quadrant. So in these cases, we can go for a laser photocoagulation. This is another case which is a fundus fluorescein angiography. This has large capillary non-perfusion areas, but there is no neovascularization. So in these cases, usually we can observe if the patient is good and comes regularly on follow-up. But if the patient is not coming on follow-up, we can laser in these cases also. So as we talked about, it can be ischemic or non-ischemic. In cases where there is ischemia and neovascularization is present, in those cases, especially we have to laser. Then there is another thing which is known as macular ischemia, and we can see that in this fundus fluorescein angiography, there are the FAZ is distorted, which is the foveal avascular zone. It is enlarged, and this signifies macular ischemia. And in these cases, usually grid laser is usually contraindicated. So now coming on to the studies, there were two. The landmark trial was the branch retinal vein occlusion study, which suggested that greater than 5 disc diameters of non-perfusion areas has a significant chances of development of neovascularization. And in these cases, they signified that it is better to laser. But in Vibrant, this was a recent study. They suggested that there is, if there is greater than 10 disc areas, then of non-perfusion, then in these cases, there are higher chances of development of neovascularization. So, as we've already talked about, if there is arteriosclerosis and AV crossing of the retinal branch vessels play important role. And at AV crossings, usually where the thick-walled arteries are present, it compresses and obstructs adjacent thin-walled veins. And this follows the virtuous triad. There is hypercoagulable state, there is stasis, and then thrombosis, which leads to vein occlusion. So again, neovascularization is the one that usually we have to treat with scatter laser. And then in long standing sequelae, there is chances of development of vitreous hemorrhage. So what does the treatment usually focus on? It is mainly to reduce the macular edema, preventing neovascularization, and treating the neovascularization to reduce the risk of vitreous hemorrhage. Usually to treat macular edema these days, because of the development of anti-VEGF, we usually start the patients with anti-VEGF. Coming on to BWAS, they set out to answer 3 questions. So the first question was that can scatter laser photocoagulation prevent the development of neovascularization? And the other was that whether it can prevent vitreous hemorrhage following the retinal neovascularization. And the third was whether macular grade laser photocoagulation improves the macular edema. So it was a multi-center prospective randomized controlled trial, and they found out that the treated eyes were more likely to gain visual acuity, which is around 65% in comparison to 37%. And also they recommended that once neovascularization develops, at that point the scatter laser should be done. So again, the visual outcome, as we can see, with laser treatment was better and less than 20/40 in 60% of the patient, while without treatment it was less, which was around 34%. So the other trial was the SCORE trial, which was another landmark trial, and it was also a multi-center prospective randomized control trial. They compared 1 mg and 4 mg triamcinolone acetate intravitreal injections with grid laser pattern, and there was no significant differences which were found in this study. And the other thing was that the corticosteroid treatment, as we all know, features a worse side effect profile, which is like the IOP increased more in these cases, and also there were higher chances of development of cataract. So the indications of sectoral scatter photocoagulation is usually to treat the ischemic complications, which is neovascularization, and also in cases where there is neovascularization in the on the iris or the angle. So it mainly reduces the oxygen demand by destroying the photoreceptors within the retina. The hypoxia is corrected and production of cytokines is normalized. And the hypoxic areas are mainly converted into anoxic areas so that there is lesser release of VEGF, and this prevents the development of neovascularization. So in PWAS outcomes also, they found out that scatter laser photocoagulation prevented the development of neovascularization and also vitreous hemorrhage in cases where there was neovascularization already. So what are the parameters that we usually use? They are usually around 200 to 500 micron size. 0.1 to 0.2 second duration is usually given, and medium white burns are given. This will be covered later on also. And other thing is that the laser spot should be applied over the areas of the ischemic areas, and especially a good fundus fluorescein angiography should be done to delineate the capillary non-perfusion areas and to laser it accordingly. Usually a 1 burn apart width is what we consider. The complications that can occur is usually choroidal hemorrhage, premacular membrane can develop, which is an epiretinal membrane. In the long-term sequelae, there can be an accidental burn to the fovea. In cases where there is extensive laser done, macular edema can develop. There can be also, if a very high power of laser is given, there can be chances of hemorrhage after Brooks membrane rupture. Then again, extensive laser can cause choroidal effusion also in lots of cases, and visual field effects is one of the problem, and also night vision problems. So the follow-up should be usually every 3 to 4 months in these cases, and as we've already talked about, after 3 months, usually a fluorescein angiography is must. And if neovascularization persists, then usually scatter laser may be added. And another thing which is very important is to do a good gonioscopy every 3 to 4 months to look for subtle signs of neovascularization. So again, CWAS said that prophylactic pre-PRP did not prevent any neovascularization. So only in the active neovascular disease, they suggested lasering until or unless the patient is not able to come to your follow-up and you know that the patient is not very compliant. So the indications of macular grade laser is usually the duration. If there is persistent macular edema and the visual acuity is less than 6/12 without significant macular hemorrhage, then in these cases, usually we should do. The most important thing to note here is that the FFA should show a good capillary perfusion. Otherwise, it is not good to laser in grid laser. Then what is the mechanism? It is mainly, it improves the tight junctions of the RP, and this was demonstrated by BWAS also. The technique will be demonstrated later on. And again, BWAS depicted a significant improvement in the visual acuity with grid laser. The recent studies which have been done are the Brighter and the Retain studies. They added laser to ranibizumab to see whether there is chances of decrease in the amount of anti-VEGF, although in their study they did not improve outcomes, but in our practice we usually laser in cases where there is persistent macular edema, and the amount of anti-VEGF that we have to give is usually lowered in these cases. So grid laser is limited now to when frequent follow-up is difficult, as we've already talked about. And there was another study which was the RELATE study, which tried to find out whether scatter laser to the peripheral ischemic areas will decrease macular edema, although they also did not find out anything significant. So again, the contraindications, as we talked about, that the macular perfusion should be checked, and if there is macular ischemia, then we should not do a grid laser. Thank you. I'll just keep it short because the time is over. Thank you.